This is the third of the 3 workshops we've planned around moisture associated skin damage, presented by Claire from Medicare Plus. Claire in a minute is going to give an introduction. The session should last an hour. Claire will be sharing the slides with me at the end of the session, and then what I will do, I will be sharing them with all the providers who have attended all 3 of the sessions, so you have got reference to the discussion. And then when we've uploaded the film onto our YouTube account, what we will do then, we will let you know that, so you can actually follow the presentation again, but using your slide pack, and you can bring up questions, etc. to anything you need to ask. Today's session, like I say, is 1 hour. There will be a time for questions at the end. You can do that 2 ways. You can do that into chat, or you can do that by, as some people have already done, is raising their hand, and that's by going on the top bar, and where you've got raise, you press that, and it's like sticking hand up in a classroom. And then I eventually will get round to you. It might take 1 or 2, so about 10 seconds to get that, because I'm on my own today doing administration as well as doing bookings as well. I remind you that while we are doing the session, I will be muting you all, and the only reason we do that is because there's so many of you on the call, we will get a lot of what we call playback. Playback is echo, and it just makes it distorted the sound. So that's why we ask religiously for everyone to go into mute. Okay, if that's as much as I wanted to say. Claire, would you want to introduce yourselves? And I will go on to mute.
Hi, my name's Claire. I'm a clinical nurse advisor for Medicare Plus. Been with the company just over a year now. I am a nurse. I'm a registered nurse. I've been nursing for about 30 years, so too many really. We have to be registered to do this role. We have to, and we have to maintain our registration. Also on the call, we've got Aaron, who is the territory manager for your area as well. So we'll get started. So welcome to the Moisture Associated Skin Damage webinar today, or otherwise known as MASD. Please adhere to your local formulary guidelines. Moisture Associated Skin Damage Clinical Overview. Our learning objectives today are discuss the structure and function of the skin, outline how MASD may occur, describe the potential implications that excessive moisture can have on the skin, outline the importance of assessment and classification of MASD, including the importance of early recognition and proactive prevention to protect skin integrity. Summarise how a structured approach can effectively manage MASD. Skin overview. Right, the skin, the largest and one of the most important organs of the body. It has a surface area of about 1.8 square meters squared and weighs around 4 kilograms. The skin contains 11 miles of blood vessels and accounts for 10 to 15% of your body weight. I have to slide my thing along with my finger. Just put these up. As we know, the skin has 3 main layers: the epidermis, the dermis, and the subcutaneous. The dermis layer is skin's visible outer layer, 5 sublayers, the top being the stratum corneum, no blood supply, outer layer continually sheds, lower layers replenish the skin surface. The dermis contains collagen and elastin fibers, gives strength and elasticity, connective tissues such as capillary loops, collagen, elastin fibers, nerve endings, sebaceous glands, hair follicles, and muscle fibers. Subcutaneous layer is your thick layer supporting the skin, contains blood vessels, insulates, protects, absorbs, shocks, houses fat for energy when needed. The acid mantle. The acid mantle is a very fine and very vital film on the surface of your stratum corneum. This is the layer of skin which sits on top of the epidermis. It is the outermost layer of the epidermis, acting as the primary barrier between your body and the environment, often called the horny layer. It is primarily made up of 15 to 20 layers of dead skin cells and tough keratin proteins that protect against moisture loss, pathogens, and physical injury. We shed between 30,000 to 40,000 dead skin cells from the stratum corneum every minute. It is built to withstand extreme environment wear and tear. The acid mantle is slightly acidic, ranging from 4.4 to 6 pH. It is the body's first layer of defense against bacteria, viruses, and harmful foreign bodies. It also prevents cellular water loss and keeps your skin soft, elastic, and supple. The acid mantle derives its name from the fact that the skin's ideal pH is slightly acidic, about 5.5. When this mantle is compromised through excessive cleaning, improper skincare, or overhydration from moisture, the barrier becomes alkali and vulnerable. A weakened barrier can't retain moisture effectively, which disrupts its ability to function optimally, making it more susceptible to irritation. The thin film on the skin surface composes of lipids from the oily glands mixed with amino acids from sweat. The acid mantle's main job is to keep the good stuff like moisture in and the bad stuff like bacteria, pollutions out. Think of it as an essential shield, an invisible mask that covers the skin. The bad news, however, this delicate layer can very easily be damaged and stripped, leaving the skin open to infection and bacteria, which damage our health, but also our visual complex. If you have ever experienced a tight feeling after cleansing, the acid mantle has been stripped. What can damage it? Over cleansing, regular use of acid peels, extreme heat, and cold, sun, air conditioning, pollutions, free radicals, skincare ingredients such as sodium lauryl sulfates. How to love your acid mantle. The good news is that the skin's pH can naturally right itself within about 30 minutes. However, the damage that is done can take weeks to repair. Functions of the skin. Right, it protects us from microorganisms, UV lights, toxins, temperature, and it is waterproof. It's a blood reservoir, extremely vascular. It houses 8 to 10% of our total blood flow. It excretes salts, water, urea, waste products, toxins, pheromones. It absorbs emollients like moisturization, medical patches, medical ointments, creams, and also harmful chemicals. Its sensation, it's got nerve endings, they detect pain, changes in temperature, touch and pressure. It's a thermoregulator, so it vasodilates and vasoconstricts. We sweat when we're hot and we get goosebumps when we're cold. Metabolizes, so it metabolizes vitamin D, which leads to calcium absorption. Communication, changes color, so we go pale, we blush, red. When we are hot, e.g. got a temperature, it also shows our emotions. The aging skin. Reduced sensation changes due to decreased blood flow to the nerve endings of spinal cord and brain. Reduced ability to feel, vibration, touch and pressure, which increases the risk of falls and injury, e.g. pressure ulcers, skin tears, diabetic foot ulcers. Reduced barrier function due to reduced sebum production, skin appears drier and thinner. Reduced strength and elasticity due to reduction of collagen and elastin. Reduced sweat glands activity, therefore tendency to overheat. Slower healing due to reduced blood flow and slower epidermal regeneration rates. Changes in distribution of fat and hair due to the reduction of sex hormone levels. Blood vessels appear closer to the surface of the skin, therefore easier to sustain skin tears, pressure ulcers, and hematomas. The effects of excessive moisture on the skin. So I just need to move my cursor. That's it. Prolonged exposure of skin to moisture impairs skin's integrity regardless of the underlying cause and specific type of moisture damage. Overhydration of the skin disrupts the barrier properties of the stratum corneum and allows irritants to penetrate the epidermis. Once the skin is overhydrated, it is more prone to physical damage, including friction and shear. Moisture-associated skin damage. MASD is an umbrella term for damage caused by body fluids in contact with the skin. The difference between the four conditions is the type of moisture that induces skin damage. Simply put, it's an irritant contact dermatitis commonly caused by incontinence-associated dermatitis, excessive wound exudate peri-wound associated dermatitis, excessive perspiration, intertriginous dermatitis, and affluent from stoma, peristomal dermatitis. All areas exposed to body fluids have potential to break down if they are not protected. Moisture-associated skin damage, IAD is the most common form of MASD. Over 14 million men, women, young people, and children of all ages are living with bladder problems. 1 in 10 of the population are affected by fecal incontinence. This population is at very high risk of developing incontinence-associated dermatitis. It is due to prolonged or chronic exposure of urine and/or stool, particularly liquid stool on the skin. Prolonged exposure of skin to moisture impairs skin integrity, regardless of the underlying cause and specific type of moisture damage. IAD rates are not monitored closely enough to ensure avoidable harm is reduced. Some trusts don't monitor or complete incidence forms for MASD. Always follow national guidelines and your local policies and pathways. Does your action reflect best practice? Best practice guidelines for moisture-associated skin damage focus on proactive, structured skin care to prevent skin breakdown, reduce discomfort, and promote healing. The core foundation of MASD management rests on 4 essential pillars: assessment, cleansing, moisture, control, and protection. Incontinence-associated dermatitis, what does it look like? Widespread diffused, blotchy erythema, red areas of the skin. Maceration, the softening and breakdown of skin caused by prolonged exposure to moisture, water, sweat, urine, or wound fluid. Patches of denudement or partial thickness erosion is the loss of the epidermis, the outermost layer of the skin. This exposes the sensitive dermis underneath, resulting in raw, painful, and weeping red patches that are highly vulnerable to infection. Erosion, irregular in shapes. Damage may be linear in skin folds, a skin condition with rashes, lesions, or changes that follow a straight or specific line rather than appearing as scattered spots. Leakage of serous exudate or possible bleeding, maybe over a bony prominence in skin folds, anal cleft, or perianal irritation with irregular shaped edges. Skin tone. We do a skin tone card, which obviously you can see on the screen. It has numbers down one side and letters across the top. And what you do with it, you just take it to the patient's underarm You assess their natural colour of the skin. You then take the skin tone card to the damaged area and you can see if there's any changes in that skin tone at all. If you want any of the skin tone cards, I'll give you my email at the end and you can just contact me. I've just had a new delivery, so I can send some out to wherever you work. Please send me your address, because people keep sending me little messages with no addresses. So the skin tone. Assessment of darker skin tone should include awareness of skin tone to monitor any changes to the patient's skin. Clinicians should be aware that skin tone is separate to ethnicity and have the confidence to talk about this in a professional way. Dark skin should not be seen as a challenge in clinical practice. Assessing skin for colour so that early identification can be made of any changes or issues should be a routine part of everyday skincare. The senses, especially touch, should be considered as part of a skin inspection assessment. Localized skin color changes can occur where pressure is applied. Areas of intact skin subject to pressure may feel either warm or cold when touched. Healed previous pressure damage may be lighter in color. The skin may be purplish, bluish, violet in color. There may be localized edema causing taut, shiny skin. Patients may indicate pain or discomfort at these body sites. The skin tone tool is a valid classification tool that shows a range of skin tones that the tone can be selected that most closely matches the patient's inside upper arm. The skin tone tool has been found to be a simple and economical way of assessing skin tone and can be used across all settings. It's also endorsed by NICE, so it's safe to use. Clinical characteristics of IAD. IAD can cause considerable pain, often burning in nature, and suffering for the individual, especially following each episode of incontinence. This is due to nerve endings at the dermal epidermal junction becoming exposed when the skin is broken. The dermal epidermal junction connects the epidermis to the dermis. Its primary role is to anchor the two layers, provide mechanical support, and regulate the transport of nutrients, waste, and cellular signals. Intertriginous dermatitis, just a fancy word for sweat, really. Intertriginous dermatitis, excessive perspiration, commonly known as intertrigo, is an inflammatory skin condition caused by skin-to-skin friction, heat, and trapped moisture. It frequently affects body folds like the armpits, groin, under the breast, and between abdominal folds, resulting in a red, itchy, and sometimes painful rash. Symptoms are red, inflamed, and sometimes raw-looking skin, itching, burning, or a stinging sensation, skin maceration, so it's soft, pale, or soggy skin, potential foul odor or oozing if a secondary infection develops. Causes. The primary causes are sweat and moisture becoming trapped in areas with limited air circulation. The combination of moisture and continuous rubbing damages the skin's barrier. This warm, damp environment creates the ideal breeding ground for bacteria or fungi, such as Candida yeast. Risk factors include obesity, diabetes, tight clothing, and hypodrolysis, excessive sweating. Excessive perspiration. Obesity carries an increased risk of ITD due to excessive sweating or I'm having real trouble with this word today. Hyperhidrolysis. This is a common condition where you sweat far more than your body needs to regulate its temperature. It often affects the hands, feet, armpits, and face. While harmless, it can be uncomfortable and impact on your daily routine. Peristomal moisture-associated dermatitis. Peristomal moisture-associated dermatitis is inflammation and erosion of the skin around the stoma, caused by prolonged contact with affluent urine or stool, sweat or pouch moisture. It damages the skin's barrier, resulting in redness, pain and leakage beneath the pouch. Key causes: affluent contact, leaks or poor pouch fitting, allowing acidic stool and urine to touch the skin. Moisture buildup, trapped perspiration under the skin barrier causes maceration, overhydration. Mechanical trauma, repeatedly tearing off adhesives can strip delicate skin, accelerating the damage. Actionable management steps. Assess the pouch fit. The most crucial step is ensuring your pouch system is sized correctly. The opening should be about 3 millimeters larger than the stoma itself. Clean gently, use warm water and a soft non-woven cloth. Avoid harsh scented soaps or alcohol-based wipes. Protect the skin. Apply a skin barrier wipe or spray like a non-sting barrier film to form a protective layer. You can also use barrier rings to fill the uneven gaps around the stoma. Peri-wound moisture-associated dermatitis. Chronic non-healing wound exudate, in comparison to acute wound fluid, is considered more corrosive and destructive to the wound bed and surrounding skin. This is due to the high levels of harmful proteolytics enzymes present within the wound bed. In chronic or stalled wounds, they are highly concentrated in the slough or eschar and within the surrounding inflammatory fluid, where they can mistakenly break down essential healing proteins. Consider the absorption and retention capacity of wound dressings that you're using. Early intervention and management of moisture-associated skin damage. We can act before there are any signs of moisture-associated skin damage. We need to be aware of patients at risk of moisture damage, of damage to skin, as damage to skin can occur in as little as 15 minutes. Every patient with mild irritation and intact skin can face itching, burning and pain when the skin is exposed to moisture. Post-inflammatory hyperpigmentation, like we can see in this photograph, is most common in patients with darker skin tones. The skin darkens after inflammation or injury, as melanocytes produce too much melanin in response, leaving the patient with darkened skin in the areas that was damaged. Any scarred skin is more susceptible to further breakdown. The scarred skin is only about 70% of the strength compared to normal healthy skin. This means the skin is more friable and at risk of friction and shearing, more so than healthy skin. So if patients are repositioning themselves in bed, or we are helping them up the bed, the skin is more at risk of breakdown due to that friction movement. So it is important to use aids such as slide sheets. Can you imagine the pain of trying to sit out in a chair with moisture damage like this? The skin is healing, but a scar has been formed. The discomfort patients feel when trying to lie or sit on that scar tissue can be difficult, stunting their progress and rehabilitation. Let's prevent avoidable harm. Why should patients have to suffer like this when early identification and management of MASD helps avoid worsening severity and complications developing? We never mean to inflict harm on our patients. This is never our intention as health professionals, but this is avoidable harm. The answer is simple. Prevention: inspect your patient's skin regularly and apply a skin barrier product before there are any signs of irritation or damage to the skin. Complications of MASD. Research indicates that patients with MASD, especially incontinence-associated dermatitis, are roughly 5 times more likely to develop pressure injuries. Development of a pressure ulceration. Incontinence-associated skin damage is a recognised risk factor for pressure ulceration, and the two can coexist in one individual. Inflamed skin has reduced oxygen and blood flow, making it more vulnerable to pressure-induced ischemia. A pressure injury can form faster and spread deeper, even if pressure, friction, or shear levels are moderate. Infections, bacteria and fungal due to skin barrier disruption. In a moist, favourable environment, microbes will thrive. Inflammation and impaired chronic inflammation reduces immune response locally. Fewer immune cells reach the skin, and antimicrobial peptides are less effective. This creates a window of colonisation and infection. Disruption of normal skin microbiota, skin flora, MASD, can alter the balance of commercial bacteria, microorganisms, allowing opportunistic pathogens to overgrow. Examples: Candida overgrowth is intertriginous areas, skin folds, or pad areas. This is the Medicare Plus skin damage meter for mild, moderate, or severe. As you can see, the meter has a green, amber, red approach for mild, moderate, and severe. Mild erythema of the skin, dry, intact, but irritated and at risk of further breakdown. Moderate erythema, less than 50% damage of the skin, oozing and or bleeding may occur. Severe, large areas of erythema, more than 50% damage, skin oozing and or bleeding may be present. Management strategies. Nurses play a key role in preventing, let me just get rid of that, early detection and management of MASD. Perform regular skin assessments. Inspect the skin routinely, especially in high-risk areas such as the perineum, buttocks, skin folds, and around wounds and stomas. Assess for redness, maceration, pain, itching, erosion, or signs of infection. Document findings and monitor for changes over time. Identify and manage the source of moisture. Address urine or fecal incontinence promptly. Manage excessive sweating where possible. Control wound exudate with appropriate dressings. Ensure ostomy appliances fit correctly to prevent leakage. Implement a structured skin care regime. Cleanse the skin gently using a pH-balanced, non-irritating cleanser. Avoid harsh soaps and vigorous rubbing. Pat the skin dry rather than rubbing. Use moisture barrier products. Apply barrier creams, ointments, or films to protect vulnerable areas. Reapply according to manufacturer's recommendations and patient needs. Select products appropriate to the amount and type of moisture exposure. Reduce friction and shear. Use proper repositioning and transfer techniques. Employ slide sheets or lifting devices when moving patients. Keep bed lines smooth and wrinkle-free. Promote continence care. Develop individualized toileting schedules. Use absorbent products appropriately. Change incontinence products promptly after soiling. Manage skin fold moisture. Keep skin folds clean and dry. Use moisture wicking fabrics or absorbent materials when indicated. Monitor areas such as under breast, abdominal folds, and the groin. Optimize nutrition and hydration. Assess nutrition status regularly. Encourage adequate protein, calorie, vitamin, and fluid intake. Collaborate with dietitians when nutritional deficiencies are identified. Educate patients and caregivers. Teach proper skin care, cleansing, and protection techniques. Explain the importance of reporting skin changes early. Provide guidance on incontinence management and prevention strategies. Collaborate with the multidisciplinary team. Consult wound care specialists for complex cases. Work with physicians, continence advisors, dietitians, and physiotherapists as needed. Follow evidence-based protocols and care plans. Skincare prevention. I know we just spoke about this barrier products as a treatment strategy for MASD, but this is just some basic skincare advice. Skincare and prevention. The first most important step is good skincare. Good skincare starts with regular skin inspection and management of incontinence where possible. We can always remove the incontinence, but we can't manage it as best. We can't always remove the incontinence, but we can manage it as best as we can. This means assessing patients for the correct incontinence garments, ensuring pads are absorbent enough or not too absorbent and fit correctly. If pads are too absorbent for patients, they will draw out moisture from the skin and disrupt the skin's natural barrier, dry the skin out, and make it further at risk. So when it comes to skin hygiene, the three main areas to consider are cleansing using a pH balanced cleanser, hydration, moisturizing using an emollient, protecting using a skin barrier product, pat or air dry, do not rub. Hydration. Humectants, emollients are water-loving hydrophilic ingredients that act like magnets and contain urea or glycerin, draw the water held in the dermis and send it to the epidermis to hydrate the outer layers of the skin. However, standard emollients just trap moisture in the epidermis by placing the layer of the surface of the skin to prevent water loss. Ensure emollients are used as a daily skin regime to ensure skin is hydrated and supple. Avoid traditional barrier creams. Avoiding traditional barrier creams, you can see what this picture here, what they can do. It's caked all over that poor person's bottom. They can contain perfume, alcohol and preservatives, may interfere with pad absorbency, can cause irritation, can increase pain, need removing at every cleanse, difficult to assess skin as they can coat it as this picture shows. The fundamental aspect of MASD prevention and management must be based on skin cleansing to remove contaminants and microorganisms, application of a skin moisturizer, and an impermeable barrier that provides total skin protection. Soap and water still remains a traditional cleansing method, however, is considered to be suboptimal care. Get my teeth round. Total barrier protection. Prevent, protect, repair, and preserve. Let's look at how we categorize and manage MASD with Mediderma Total Barrier Protection to prevent, protect, repair, and restore. Mediderma S film for mild dermatitis provides barrier protection on intact skin or mild skin damage. Apply a pea-sized amount to the palm-sized area of the affected skin twice a day or after every third cleanse. It's alcohol and preservative free, contains silicone as a water repellent. Skin should be completely dry before application. Does not affect incontinence, pads, nappy absorbency. Also, when you've put the cream on, leave the cream on for a few minutes, let it soak in, let it dry before you put a pad onto anybody's bottom that you've put a barrier cream onto. If you don't, the pad will just stick to the cream and stick to the skin. Mediderma S film for intertriginous dermatitis. It's alcohol free, preservative-free, non-sting formulation, indicated for mild to moderate skin damage, does not affect pad absorbency if used for IAD, long-lasting protection of up to 72 hours, can prevent MARSI. If none of you know what MARSI is, it's a thing called medical adhesive-related skin injury. Medical adhesive-related skin injury is when we're continually removing an adhesive from the skin. So it could be stoma pouches, it could be a dressing that you're removing every day. When you continually remove an adhesive from the skin, it tears at that acid mantle, that stratum corneum, and then breaks down into the epidermis, causing damage to the epidermis, and that can cause lots of damage, like your IADs and things. So you need to protect that area at all costs. If you're going to put an adhesive onto somebody, especially stomas, every day, you need to clean that area, you protect it with a film, wait for it to dry, you then put the adhesive on. Mediderma S film for peri-wound dermatitis. As we said, it's alcohol-free, indicated for mild, can be used every 72 hours. You will be getting these slides. I'm not going to repeat what I've just said. But that's what it can be used for, any sort of peri-wound. Fantastic on peri-wounds. As a wound nurse, I use a film on my peri-wounds all the time. It stops all that horrible maceration and further breakdown of the wound. Mediderma Lifties and Mediderma S film for peristomal dermatitis. Lifties is a healthcare grade silicone based medical adhesive remover designed to painlessly dissolve and release sticky medical tapes, dressings, stoma ostomy pouches and catheter devices from the skin. It is alcohol-free and formulated to prevent skin stripping, irritation and damage during removal. Also use Mediderma S film around the stoma site to protect and help the pouch adhere better. If you put a film around a stoma site before you put the pad on, the actual pouch will adhere much better than it will adhere to your own skin because of your acid mantle. It makes it a bit oily. And the pouch can fall off. Whereas a lot of stoma patients will say if they've used a film, then put their pouch on, it stays on better and there's no damage either when they take it off. Mediderma Pro Cleanser and Ointment for severe dermatitis. Mediderma Pro spray is pH balanced, alcohol and preservative free, no rinse, moisturizing cleanser suitable for use on moderate to severe damaged skin. You can also use this around stoma sites. You can use it on wounds for intertrigo, so your sweat rashes. It's also got surfactant in it, and what surfactant actually helps to do is when you spray the cleanser onto the wound area, it can go straight onto the wound, it won't damage it, it won't harm it, will actually clean it. What the cleanser will do is if you put it on and leave it on for a little while, it helps to break down some of those nasty enzymes and nasty things that are in that wound or around that stoma area. To bring it off. What it does for incontinence associated dermatitis, if you spray it directly to the skin, I always advise people to warm the bottle first because you don't want to just spray cold cleanser straight to somebody's bottom. Warm it first, spray it directly onto the skin if you can, because it will break down that urine and feces. If you can't, use a dry cloth, non-wet, obviously dry. Don't wet it because the water will dilute the cleanser. Spray the cleanser directly onto the dry wipe, pop that onto the affected area, leave it on, spray some cleanser on top, just leave it there for a little while and it will start to break down and you'll be able to clean the area much easier. Mediderma Pro ointment. Apply Mediderma Pro skin barrier ointment at every wash. So it's not like the film and the cream where they're either twice a day or with your films every 72 hours or every third wash. This is every time you cleanse, you have to reapply your ointment. So Don't forget that. It's tacky consistency, adheres well to moist skin, and can be used over topical medications, i.e. antifungal creams. If you've got somebody that's got a fungal infection under the breast, skin folds, or anywhere, you clean the area, you dry it, you put your antifungal cream on, leave it on for a couple of minutes, then you can apply the Mediderma Pro ointment on top of that antifungal cream, and it will actually keep it in situ a lot longer. Also, the great thing about the ointment, if you put it under a breast or a skin fold, if you don't spread it out properly, don't worry too much, because the way our skin slides against itself when it folds over, it will spread that ointment out into the areas if you've missed any. If skin does not show signs of improvement after 72 hours and it's rapidly deteriorating, seek specialist advice. If the skin on your patients or clients is not improving, it's not due to the ointment. There's something else going on. And you need to get either a nurse in or take a swab of that area to see if there's something going on. Get the doctor in. There's obviously something going on if the ointment doesn't work. Okay, so always remember that. Don't just think, oh, it's the blooming ointment or it's the cream, it's useless. There's something else happening. This is our total barrier protection and step up and step down approach. So the step up, step down approach with Mediderma products is a clinical strategy used to manage moisture associated skin damage, MASD, and incontinence associated skin damage, IAD. The approach scales the intensity of skin protection based on the severity of the damage. How the step up, step down pathway works. Step ups for severe damage or breakdown. When to use. Use when the skin condition worsens, such as when dealing with severe IAD, excoriation, broken skin, or high levels of bodily fluids. Products switch to a multi-stage regime consisting of the Mediderma Pro foam and spray for gentle cleansing of the dried on fluids, and the Mediderma Pro skin protectant ointment. The ointment creates a robust water resistant barrier on broken skin to allow healing without stinging. Step down as the skin improves. When to use. Use as the skin integrity improves, inflammation decreases, and the area is no longer broken or excoriated. Product transition from the ointment down to the Mediderma total barrier film for maintaining protection. As healing progresses, further scale down to the basic Mediderma S total barrier cream for daily maintenance and protection against friction and moisture. If you look at these pictures, these are pictures, and these were real pictures that were sent to us by nurses where they'd used the products, and they'd started off like the first picture. If you look at the very first picture, this was used, Mediderma Pro was used on this person until they got down to the picture underneath, the IAD picture, and they then stepped down straight down to Mediderma S cream. You can step up from cream to the Pro if you wish, or you can step from the Pro straight back to the cream. You can miss out the film, or you can use the film, or you can step from the Pro to the film, or step from the cream to the film. It's entirely up to you. It's what you think you need at that time. The second picture, this was a real lady who'd had these wounds on her leg for a long time. They used the Mediderma film, then stepped down to the Mediderma cream in the second picture as she'd healed. The third picture was Mediderma S film, then stepped down to the Mediderma S cream, or you could carry on using the Mediderma film if it was into Trigo, because this looks like it could well have been into Trigo. If it is into Trigo, you can use the film or the cream. If it's broken skin, obviously you'd use the film. If it's not broken, you're quite well within your rights to use the cream. That's not a problem. This is a picture of your actually Lincolnshire Community Health Services pathway. Aaron has got a load of these. He's bringing them out to Lincolnshire and will, if you ask us for them, we actually will, Aaron will post one to you or post them to you, or get in touch with Aaron and he'll just ask him if you can have one. I'll give you our emails at the end of the presentation so you can contact us if you need to. But this is your pathway and this is what you're supposed to be following. Total barrier, sorry, bringing total barrier protection and SMART into practice. What we offer, product access, sorry. So you can get all of our products on FP10, supply chain or Bunzl Healthcare, very accessible. Training, we offer free training to anybody on anything, well, obviously on MASD. We offer training on MASD versus pressure, things like that, anything you need training on, obviously around moisture associated skin damage, we'll quite happily come out and do training for you. Or we do webinars, obviously Teams training, anything you want really. You just contact us and we'll quite happily do it. We produce pathways, we design and produce the pathways for the trust to the trust specification. So we'll go to the trust, we'll speak to the nurses, see what they want, usually the TVNs. They'll tell us exactly what they want for that trust. We have a hydration pathway we use and we take out, and we do actually take out pathways from other trusts we've done to show people. So we develop it, we print it all off, and then we deliver it. Product variation, obviously we have the total barrier protection from cream, film, cleanser, pro to lifties. Once you start using our products, you don't have to use any other products. You don't have to think, oh, I need Pro Shield or I need Cavalon or Sorbiderm, because our products cover all of those. Everything we do is evidence-backed. Everything we say or train on is evidence-backed. With literature, we have published papers from TVNs such as Luxmi Danoon, who wrote a paper on improving skin integrity and reducing MASD, an early intervention with Mediderma Pro ointment, Step Up Early. You can get that paper if you contact us. I'm quite happy to send you that paper, or I'll send you in the right direction to get it. We do auditing and evaluation services. We provide samples and paperwork and support. So if you wanted to audit or evaluate any of our products at your place of work, we'll bring in all of the samples, all of the paperwork, and we'll support you in doing that. This is the skin moisture alert reporting tool, which is how we do a thing called a smart card, which I'll show you in a minute. This is how the smart card was developed from Smart Integration, the assessment tool endorsed by NICE. This resource supports the implementation and recommendations in the NICE guides on pressure ulcer prevention and management, urinary incontinence and pelvic floor organ prolapse in women management, fecal incontinence in adults management. You can get all these things off our website, or I can send them to you or get them sent to you. This is our smart card, a convenient wearable version of the smart resource which I just showed you by NICE. This is quite safe. It's NICE endorsed, so you can use this safely. You're not going to get into trouble. So on this one side, you've got IAD from mild, moderate to severe. On the other side, I don't know if you'll be able to see it because of my background, but it's just a card. On the other side, you've got peri-wound, peristomal and intertriginous. And basically it tells you to prevent and restore, protect, repair and repair. So it gives you a brief outline of it'll give you a picture, a brief description of what's wrong and how to actually manage that scenario of what you're looking at. Okay, these are a really good tool. If you want some of these, either contact Medicare Plus, they'll send you some out along with the skin tone cards if you want, or contact me. I'll gladly send some out to you to your place of work. We have lots of resources available for you on our website, quick guides, e-learning modules and clinical articles. They can all be accessed through the Medicare Plus website .co.uk. Right, I'm just going to ask you a couple of questions now, and all you have to do is just put your thumbs up or react to, or put what letter you think it is, either A or B. Why is hydrating the skin so important? It rehydrates skin to prevent comfort from itching, or B, it rehydrates the skin to optimize the skin barrier, reducing skin or ulceration and infection whilst providing comfort to itchy, irritated skin. A or B? Yeah, absolutely. B. Yeah. Well done, everyone. Well done. There you go, Aaron. Everyone's got it right. They've listened to me.
Well done. Well done, everyone.
Well done. Yeah. And the second one, how is moisture associated skin damage categorized? How do we categorize it at Medicare Plus? Grade 1, grade 2, or grade 3? B, irritated, excoriated, or broken? C, mild, moderate, and severe? We categorize it as C, mild, moderate, and severe. Okay. Different places categorize it at different ways. But if you go to any conferences, study days, you'll notice a lot of the companies that you come up against will also be using the mild, moderate, severe now as well, the same as us. Right, to summarize. Summary. We've outlined the clinical presentation of MASD, defined the classification and severity of damage, demonstrated the importance and prevention of early intervention to avoid harm to patients and the development of pressure ulcers and infections, discussed how clinical pathways can guide our practice to implement management strategies, demonstrate how a total barrier protection strategy can prevent and treat the 4 pillars of MASD. These are all the references. You'll get these anyway. You'll get the references. They'll be sent to you because you'll be getting this presentation. So don't worry too much about the references. Right, you can turn your mics off now if you've got any questions, anybody, if you'd like to ask anything at all. I'm quite happy to speak to you.
So you either can raise your hand or you can just put something in the chat.
Yeah. For those who would like any smart cards or pathway, please email me. I'll just put it in the chat box right now. And please provide full address and how much smart cards you would like.
Yeah, and I've just put my phone number up and my email address. So please, I've had a lady that keeps emailing me at the moment asking for some smart cards and skin tone. I keep emailing her back saying, yes, please, but send me your address. And then she just keeps sending back saying, thank you. So please, I need your address if you want Aaron or I to send you any of the smart cards or information. We're quite happy to do that, but please send your address. If you want us to do you an order, we can get stuff sent to you from Medicare Plus ourselves. We can do a little order and get it sent to you. You can access our website for any of our information as well. If you go onto the website, you can order the smart cards, skin tone cards, literature yourselves if you want to. We do a really good poster, pressure versus moisture, which is absolutely fantastic because it gives you 5 pictures of pressure, 5 pictures of moisture, and also the how to look at them, what they do, the differences in them, and everything else.
So Sean's Sean's put something. I know the answer to this. Sean's asked, are there any comparable companies with similar products? So what Claire's talked about, there is actually a Lincolnshire formulary which has got all the agreed formularies from all the different companies which have been agreed by the ICB for their products. If it's not on the formulary, we are not to use it. It has to be on that formula. Yeah, and that's through prescription or through bought privately. But you all would have copies of that somewhere.
We're the only company that do a total barrier protection with a lifties as well, with an adhesive remover. So we do the cream, the film, the ointment, the cleanser, and the adhesive remover. That's why we're quite unique compared to a lot of the other companies. The companies will probably only do cream, or they might just do ointment. things like that, or they might do cream and film, but they don't do the ointment. There's only two companies that actually do the ointment, and that's us and our Pro Shield actually. The only difference between our ointment and Pro Shield is ours doesn't have any fragrance in it. I used to work for the company that sold Pro Shield, and I didn't know it had fragrance in it. I only found out a couple of months ago that Pro Shield is actually fragranced to make it smell a bit nicer. Ointment and cleanser are not fragranced at all, so it's actually safer to use. Not going to cause any damage.
Thank you, Claire. Okay. We've had our hour up. If there's no further questions or any questions, like I say, we will be sending out copies of the slides. We have recorded it. If there's any questions, Aaron's put his emails. Claire's going to put her email into the chat anyway. Or you can contact us directly here at Care and Links and Linker, and we can pass on any comments or any requests both to Claire and Aaron. I like on behalf of Care and Links, thank you all for attending today. Have a good day. To Aaron and Claire, thank you for the last 3 sessions. It's been a pleasure. We'll have to catch up shortly and look about do something, another program maybe.
Absolutely. Thank you very much, everybody. Thank you for taking time out to join us.
Good time, guys.
Thank you so much.
Bye.
Thank you.
Bye.
Bye now. Bye, everybody.
Thank you. Bye.